Well, hello everyone. Welcome. It's 7 o'clock. It's Monday. It's the Royal College of Surgeons of Edinburgh, and it's time for our weekly webinars. And this week, I'm delighted to say we are addressing cardiothoracic and vascular issues. And before I introduce our chair for the evening, Mr. Tim Graham, who many of you will know, I just want to update our members and fellows who are tuning in now into what the college is doing during these difficult times. The college itself is closed, as I've mentioned before, but is virtually very much open here for you all. And education continues, and we have a huge series now of webinars now available live, as we are today, and of course accessible on the website archive as well with podcasts. Now, the college is really very much therefore open for support, guidance and advice regarding any aspect of education and assessment. And not only have we run all of our major committees for the college, we've run council in the last week, and the council development sessions are all done virtually and very effectively and very successfully. We even ran the 4 Royal Surgical Colleges Presidents meeting last Monday, which would have been held up at the college, and our full Joint Surgical Colleges meeting last Tuesday. So we are very much open for business. We're working persistently to support all of you who are devoting your time working at the front line on behalf of the NHS. And we've strongly supported the need for the appropriate PPE. Many of you will have heard of me saying this, and that you must make sure you're adequately protected for the clinical scenario you find yourself. I believe we've been very successful in helping Public Health England to revise their guidance. We stood up and we were counted, and when we felt things weren't going the right way on behalf of our fellows and members. This last week, we've been addressing the recovery period issue, and particularly the plight of cancer patients who've had much of their treatment delayed and postponed. And we're really getting that high up on the agenda, and indeed in the 5 o'clock press conference, this was addressed, and I'm pleased that we're moving forward on it. And finally, the hotel, Tenhill Place, has provided a safe haven for over 300 healthcare workers and 1,500 nights, helping them to complete their shifts and provided food and sustenance day in, day out, so that they can look after us in the front line, and our fabulous staff can look after them and keep them safe, well and rested. Tomorrow, our next training seminar is the issue of redeployment in critical care. So if you're a trainee, please join that tomorrow at 7 o'clock. And next Monday, a week today, we're looking at the issue of recruitment for trainees. So please join us for that. Now, we've got an outstanding panel tomorrow, which includes Katie Hurst, who's one of our trainees committee, who's chairing it. And we've got the president of ASIT, Josh Burke, and the president of BOTA as well coming along. So a lot to look forward to. So now I'm going to hand over to Tim Graham, who is going to introduce our superb set of panelists. Thank you, Tim.
So thank you, Mike, and good evening to everybody. Thank you for joining us. If I can just introduce our panel this evening. First of all, we have Andrew Garnham, who is a consultant vascular surgeon in Wolverhampton and the Black Country, and he's the chair of the vascular surgery SSB at the college. Secondly, we've got Mr. Sri Rathinam, who's a consultant thoracic surgeon in the East Midlands in Leicester, who's chair of the Cardiothoracic SSB in the college, but also one of the education secretaries for the Society for Cardiothoracic Surgery in the UK. Thirdly, we've got Mike Lewis from Brighton, who's consultant cardiac surgeon, who's also involved with the SSB at the college and the recently demitted Cardiothoracic JCIE board chair. And we're very pleased to welcome Edward Caruana, who's an NTN trainee in the East Midlands. So thank you all of you for giving up your valuable Monday evening. So first of all, I think what I'd like to do is ask you really for some general comments regarding the impact of the COVID-19 epidemic on your specialty. And maybe if I could ask you, Andrew, just to make some opening remarks.
So vascular surgery has seen much change, I think, since the COVID epidemic. If you look at our guidelines, they're on the Vascular Society website, but we've looked at prioritising aneurysm surgery, and certainly we're looking, because of the risk of doing aneurysms at 7 centimetres or above. Carotids have moved much more to emergent carotid surgery and crescendo TIAs rather than patients being referred by stroke physicians as a routine. And in fact, if you talk to our stroke physicians, they've seen a vast reduction in the number of referrals they get. We've also seen a very big decrease in our critical limb ischemia referrals. And it does make us wonder whether there's a lot of patients out there with critical limb ischemia that aren't coming for treatment. And I think one of the challenges that we will face, given this epidemic, is actually restoring public confidence in coming for surgery. I think that's going to be some time coming. I think I'm pleased to say that our trainees have done a superb job of actually getting something called the COVER study up and running. And anybody who wants to look at that can look at the Vascular and Endovascular Research Network. So if they search VERN, they will get access to a trial that is NHIR sponsored and will be open to an international audience. And it looks at actually the changes we've made in practice. It also looks at what's happened to our patients. And I hope we'll get some outcome data from that about what's happened to our patients in the COVID era. So I think the biggest challenge that faces us now is what we do on the way out. How are we going to reset our surgery pathways? So we've recently looked at the NICE guidance in aortic surgery and suggested that actually endovascular surgery may not be as good as we perhaps thought it was. However, when we look at the potential of putting patients to risk, the risk of going into an intensive care unit with open aortic surgery now seems to be significantly higher. So will this change how we make the decisions for that surgery? Clearly, we have to consent for exposing people to a risk of COVID, and that is, I think, an unquantifiable risk at the moment. What about the unit factors? You know, what about our staffing? And a lot of our theatres are not shut because we can't staff them as surgeons, but a lot of our staff are actually staffing critical care beds at the moment. And how long will it be before we can deal with that? And indeed, can we separate the flows of patients into COVID light areas? Because I think we won't get a situation where we have a COVID-free hospital entirely. I think there's a big issue about mitigating risk. And I think that's the main issue that we need to concentrate on. And there's an issue for our workforce in terms of the resilience, because they've all been working on fairly intense rotas, and there will need to be a period of adjustment. And I think for our trainees, one of the biggest issues we will have is coming round to doing major surgery again, and actually, rather than the pressure to entirely deliver service, to actually put some time in for training on the procedures they've missed out on. So I think I'll hand back to you, Tim, and get a perspective from cardiac and thoracic surgery.
Okay, Thank you very much, Andrew. I think it's worth just reminding ourselves that we've actually got both a national and an international audience this evening, which consists of both established surgeons and surgeons in training. So it's important that we think about that. We have, you're aware to the audience, to the people that have joined us, that there's the opportunity to ask questions via the question and answer section on your screen, and we'd very much welcome those, and we'll try and get round to as many of those as possible. If I could ask you, Mike, from a cardiac surgical perspective, and I appreciate you're an adult cardiac surgeon, what's the impact of the C-19 epidemic on that part of our specialty?
Well, clearly I've got experience of UK surgery. I'd have to take advice from some of our questioners from overseas. But in terms of the UK perspective, I think it has been variable. I think some areas have really struggled and had a huge upshift in cases presenting, and that's made a really big impact on their service. And I recognise that a number of centres around the country have effectively stopped providing anything but emergency cardiac surgery. Locally here in Brighton, we managed to keep going with a steady stream of urgent patients up until about a week ago. We've had a pause for about a week, and we're looking to restart towards the end of this week, early next week, to restart our urgent patient workload as ITU facility and so on reopens and becomes more available to us again. I think Andrew sums it up nicely. I think we're now at the phase where we're starting to look towards what's the new normal. What will service look like in a post-COVID world, and how will we, as cardiothoracic and vascular surgeons, fit into that? How will our services be able to be delivered with all the concerns around patient safety, healthcare worker safety, other patients who may be disadvantaged by us taking up ITU resource? All of those things need to be put into a balance. And at the moment, we really don't have, I think, enough information to allow us to accurately say to a patient what's the risk. And clearly, I think that probably is going to, in a complicated way, going to be somewhat variable around the country and around the world, depending on what the local prevalence of infection might be. That's clearly going to impact the risk of a patient coming forward for an elective procedure and ending up with COVID during their recovery, and that prejudicing their recovery. So I think we are in a point of change. I think perhaps, certainly in the UK, it looks like we're hopefully reaching the flattish bit of the curve, and hopefully as time goes by, our case incidence will continue to fall away, and therefore we'll be able to start looking forward with a bit more certainty. But at the moment, we're still at that sort of uncertain period where we're having to now think, as I say, what will tomorrow look like? And I think that's the challenge for us going forward in terms of delivering our service. That, of course, will have impacts on patients, because we've got to think of the risk of a patient sitting there with something that is potentially life-threatening and weigh that up against the risk of us operating on them and giving them COVID, or them getting it during their recovery phase, and the impact that might have on their recovery. So there are a number of parts of the equation and a number of things that we need to put together to try to start looking forward. As I say, at the moment, we're just getting to that point in the UK, and I suspect that's probably a similar position in many places around the world.
Okay, Mike, thank you very much for those comments. Sri, if maybe I could move on to you, really. I mean, thoracic surgery, the issue to some extent revolves around the management, the prioritisation of patients with lung cancer. I just wondered if you'd like to make some overall comments regarding the situation with that.
Thanks, Tim. Could we have the first slide, please, Ryan? So we are slightly different to Andy and Mike in that we deal with cancers, and UK prides itself in having a holistic cancer treatment pathway with a shorter optimum lung cancer pathway, plus the other cancers or non-cancers which we deal with in treatment to target. Slide, please. Now, all of that has changed with the COVID pandemic. We're still having patients who need curative resection diagnosis, and the other specialties who interrelate with us, the oncologists and respiratory physicians, look up to us to give them the diagnosis so that we can proceed with care. There's been a major implication in terms of capacity with our theatres converted into intensive care beds to accommodate for the COVID surge. Our staff are working in the ITU. So from having 7 full days operating, we are now down to 2.5 days. So we have to rationalize our patients. We've always prided ourselves in the United Kingdom of offering surgery to fit octogenarians, good patients, but they are the cohort who are at the highest risk in the pandemic. So we're having to rationalize and select patients who we would offer surgery, because most of our patients have a compromised respiratory function or cardiac function, or we will take away part of their lung, leading on to that. Slide, Ryan. So the implication of this pandemic is on resource limitation with theatres and intensive care. There is a patient's choice. Andy already alluded to it, saying patients are scared to come into the hospital. But the key is counseling them candidly, saying what will their morbidity and mortality be in normal circumstances as opposed to in a pandemic situation. The care has evolved, or the pathway has evolved in the last few weeks with guidance from the intercollegiate guidance as well as the SCTS. So we're now almost streamlining patients, advising them to self-isolate. So these are patients who are cancer patients who are fit to have an operation and want to have an operation. Clearly, there are also challenges in the operating room. Do we do it thoracoscopically or do it openly? Because you want to do a shorter operation because everybody is wearing a full FFP, including the face mask, the goggles, and everything. Bronchoscopy is very aerosol generating. And preoperatively, you also have the challenge of not having frozen section because pathologists won't do them. Next slide, please. And post-operatively, going forwards, we're looking at mechanisms of having a COVID-free zone and a COVID suspect or COVID-positive zone, because we don't know how long this pandemic will last. The other key thing which thoracic surgery has an issue is the chest drains, which when they bubble can be aerosol generating. So we recommend using a closed loop digital drainage system to minimize the viral load. Clearly, it's been said before, all of this has an implication on training. So we're trying to maximize the opportunity so that the trainees do not compromise their training in this time frame, but going forwards have a structured plan. On that note, can I introduce Edward, who is one of our NTNs, as well as the trainee rep on the Cardiothoracic SSB, to share a survey which he did for the SSB on the cardiothoracic trainees of UK. Over to you.
Thank you very much, and thank you to everyone who's still around after our interruption. So the thinking behind this actually was that trainees form pretty much a significant proportion of medical workforce being redeployed in the current pandemic. And implicit in that is a significant deviation from our established training pathways, but also potentially a learning opportunity that is hopefully quite unique to definitely our training time and hopefully our entire careers. So together with Akshay Patel, one of my colleagues in the West Midlands, and Simon Kendall, who's the president of the Society for Cardiothoracic Surgery, and Mr. Ratnam, who's on this panel, we've conducted a survey restricted currently to cardiothoracic trainees, just to get an idea of how this has actually impacted both our well-being and also clinical practice and training progression. Next slide, please. So the delivery was through an online survey. We had a 2/3 response rate, which considering the current circumstances is hopefully pretty representative of the national NTN training body. Next slide, please. Reporting across 4 domains, the results aren't entirely unexpected. So 2/3 of our colleagues who responded said they were at least somewhat concerned about their physical well-being. 1/3 expressed concern about their mental health. in the limited time period, so this was only 3 weeks that we delivered the survey after the lockdown in the UK, a third of respondents had actually taken time off work as a direct result of the COVID pandemic. Most of those were isolating. A small proportion had symptoms and confirmed COVID infection, with colleagues taking an average of a week off, ranging up to 18 days. From a practice point of view, over half of the people who responded had been redeployed to cover some other specialty. So ranging from covering cardiothoracics as a combined specialty to covering other surgical specialties, to the majority of whom were actually now covering medical patients, including patients acutely unwell with COVID and also intensive care. Interestingly, 86% had direct contact with known COVID-19 patients. A third had operated on a positive patient. And what was quite interesting to us was that actually a third of colleagues who replied felt that they had encountered dilemmas in the care that they were delivering to patients in terms of futility and in terms of the ethics of what we are currently able to provide. There's undoubtedly a complete shift in clinical exposure. There's a 50% reduction in outpatient clinics. We've had a significant reduction in trainees attending MDTs. There's been a very significant reduction in trainees' operating time, and implicitly an increase in the amount of time trainees are spending delivering ward care, as well as an increase in the time dedicated to structured learning. About 90% expressed being concerned about the impact of this on their training. And looking at this in a bit more granular detail, there was only 14% of respondents who felt that the learning currently, even if not directly mapped to a curriculum, was at least comparable to the pre-COVID era. And this is something that we felt could potentially have been a little bit higher given the unique nature of the current situation. Also very interesting is that 70% of respondents actually reported that they felt that even with the current level of disruption, or a level of disruption to a similar extent lasting 3 months or less, that they would wish for an extension to their planned training time. And this was no different across seniority or across regions. So quite interesting in terms of the impact, as many of my colleagues on the panel have actually alluded to. Thank you.
So please, thank you, Edward. I suppose I'll start the questions and come straight back to you, Edward, and say, do you think that trainees would prefer to have their training time potentially extended, or do you feel that they would prefer to go through the assessment annual review process this time and potentially pick up on their training in the next year or so? Did you get a feel for that?
I think one feel that we got from the survey was that there's significant variation in the experiences that people are having. And there's a whole range from people who are stepping up and getting similar levels of operating to others who are probably the majority, wherein the operating especially is significantly less than normal. The other thing that came across quite clearly is that trainees wish this to be assessed on an individual basis, and that there has been an express wish for there to be flexibility in terms of the options available, also with a view to assessing the actual quality of training delivered over the months emerging from this current pandemic, or the acute phase of COVID-19, to see what the new norm and what the new quality of training is actually going to be. I think you're absolutely correct. It's not only about quantity and duration, it's about quality, but that's harder to measure and currently a very big unknown for myself and a lot of my colleagues.
This session wasn't primarily intended to be a session for the trainees, but your comments are well made, and we very much appreciate it. I think my understanding will be, though, that trainees will almost be dealt with on a case-by-case individual basis in the annual review process this time over the summer, and that those trainees at key transition points, those that are getting CCT, those that are potentially going to go through to sit the exam, those that are coming towards the end of core training or potentially the end of ST2 in cardiothoracic surgery, those will be very carefully looked at. Maybe that not all the trainees get a review this year and will roll over into the following year, but it will be on a case-by-case basis, I understand, with the TPDs. And the principle, of course, will be patient safety, maintaining standards, but trying to ensure that no individual trainee is disadvantaged. And I think that there'll be a lot of effort put into that, certainly from the School of Surgery perspective. If you don't mind now, I'll just broaden the discussion back out a little bit. I think we've got some interesting questions coming in down the right-hand side. Betsy Evans from Leeds. Good evening, Betsy. This is a question, Mike, for cardiac surgery. What's the opinion in terms of having to quote an increased risk to cardiac surgical cases during the pandemic? What's your approach to risk assessment with patients and their families, particularly as Betsy says, we're used to being quoting surgical risk based on relatively well-refined scoring systems. Mike?
I think we are in a new world, as I said earlier. I think this is now a period of change and of challenge. We all recognise that for a patient who's gone through a big heart operation, for them to either come in with COVID and develop it as they recover or to catch it in their post-op phase is going to very much impact on their recovery and potentially threaten their survival following surgery. So there is a real question here. Of course, it's very difficult to put numbers to that, and that, as I said earlier, I think will depend on where you are in the world or where you are in even the UK, where prevalence will be different, and therefore the chance of someone picking up this infection immediately after or during surgery will be, during their time in hospital having surgery, will be will be different, and therefore it's going to be very difficult to actually put a number to it. And that, of course, that number will change over time as prevalence changes around the world and around the UK. So whilst I think we all accept that there is an increased risk, I think putting a number to that risk, and as Betsy says, I think we're very used to being reasonably accurate with our patients as to what we think the risk might be. I think it's going to be very difficult to actually be very defined about what that risk might be for patients. I think we're beholden to try to reduce the chances of picking up the infection, and I think there are some fairly sort of strict algorithms being developed which will hopefully protect patients as best we can. But I don't think any of us feel that those algorithms will be 100% effective in preventing patients from developing COVID at such a critical time. And so there will have to be an adjustment, but that adjustment is going to be a little bit of a guess, I'm afraid. I think personally, I don't know what you the rest of the panel think, but I think from our perspective, it's going to be very difficult to give patients an accurate representation of what that risk is that day, that week, with whatever the prevalence is around and what exposure they may have either during or after their surgery.
Thank you, Mike. Sri, any comments from a thoracic surgery's perspective about the risk that we should be quoting to patients?
It's difficult, Tim, because we do not have that information. If you look at the COVID publications of the initial patients who have been operated, the perioperative mortality is as high as 30%. And if they did not have a respiratory complication, it is 5%. But if they had a respiratory complication, it goes high. And this is all comers, both emergencies and elective procedures. So what we tell them is we can't give them an accurate risk. the risks are multifold, with multivarious causes contributing to that risk. And only time will tell, and we are all contributing to the COVID surge registry to look at, can we actually tease out and find out what the risks are. There are units where positive patients have 100% mortality in thoracic surgery in UK. So it varies between units, and it's very difficult to give them a number.
Okay, Andy, from a vascular surgical perspective, what's your sort of position on quoting a risk to cases? You've also got scoring systems that you will use in your elective practice.
Yeah, I think the difficulty with all the scoring systems is none of them account for COVID. And I think that makes it a real challenge. And I think part of it, and yeah, it's interesting talking to colleagues around the country, is that the rate of COVID is so different across our hospitals in the UK. And therefore, I think the risk of catching COVID, if you're admitted to a critical care facility, will vary dramatically across the country. And I think part of it is actually the prevalence in your hospital, and of course in those of us who are caring for you, because we still don't know what the rate of transmission is from healthcare workers. So we may see that in due course.
So potentially individual institutional factors. So there may be an institutional risk, and maybe a little bit like sometimes we call institutional stroke risk for patients. Edward, if I could just sort of take everybody in turn and break things up for you. I've been asked by Sunil Budia about, from your survey or from your knowledge, are you aware of trainees getting opportunities in areas such as resource management, service planning? So what I'd call more general professional skills, things that maybe have help in future careers. What's the sort of position on that?
Absolutely. I think it's more prevalent in people who have remained in the parent specialties, who have remained in cardiothoracics in our case. Unfortunately, obviously, those colleagues who have been redeployed to other specialties will have less of an oversight, less of a management level contribution. But this is definitely something that has been identified. Complementary to that is a lot of trainees who've actually expressed engagement and opportunities for research and for research at a national and international collaborative level. I think both of these are positive impacts that we've seen, although potentially the reach isn't quite as extensive as one may hope.
And I'm sure you're aware that it is possible on ISCP to identify supervisors other than surgery and have these other experiences logged on and potentially sort of reviewed. So I think there is some potential values at the moment, but I would emphasize that trainees should record where they are, where they've been deployed, and what they're doing. So quite a tricky question from Prof. Punjabi at the Hammersmith. Good evening, Prof. This is really a question about the risk of undertaking cardiological management of what would be regarded as a straightforward cardiac surgical patients. So, for example, patients getting a TAVI rather than a surgical AVR. Are the risks changed? And of course, there's the same question for you, Andy, in terms of endovascular versus conventional surgery. So, Mike, do you have a position on that? You work in a TAVI centre, for example.
Well, of course, when the trials that defined our practice were performed, COVID didn't exist, and so we weren't having to factor that into either side of the equation, whatever we're comparing with cardiac surgery. And so, of course, one has to make a best guess as to what one might think the impact of cardiac surgery versus some of the perhaps less invasive for patient treatments might be. And certainly as a starter in our unit, we've taken a fairly aggressive approach. We've been through all of our urgent patients who are on the waiting list and looked at them all and seen if there is either something that we can do to palliate for a while, to allow the COVID epidemic to drift away and therefore to give us time, or even to try to deliver some sort of definitive treatment for all of those patients. Of course, what we've got to try to do through all of this is to try to keep our patients as safe as we can. And, you know, if we save them from dying from COVID, but allow them to die from their whatever disease they have, then we've done them no favors whatsoever. And again, this is really difficult stuff, because we don't know. We just don't know where the new balance should lie. How much should we be pushing patients towards therapies that allow them to come in and go home very quickly with short periods of intensive care, if that's needed at all, versus what we can traditionally offer. And the seesaw, as balance of that is yet to be really very clearly seen, I suspect. Again, going back to the idea of trying to keep COVID out of our surgical patient cohort, I think that's a really important part of keeping people safe, and trying to get them through what are some, fairly insulting, physiologically insulting operations for them, whilst COVID is still sort of playing around in the background. So I think we have to, as we start to talk about, take a very broad thought process around these patients. And one thing that I've really come to appreciate with what we've been offering in Brighton is that we've taken an ever greater multidisciplinary approach into the management of these patients. And whereas, I think cardiac surgery, thoracic surgery, vascular surgery have all got very used to using the MDT approach, I think this epidemic gives us further encouragement to really look at the patient as broadly as we can, and to really think as best we can with whatever knowledge we have of whatever might be going on with COVID at the particular time, how that might impact, and therefore try to get the best solution for each patient. And that's essentially what we've done as our start off with our patient cohort. We've taken our urgent patients, as I say,
and carefully record the scope of the discussions and the decision made within that MDT.
Right, yeah.
Because this may be very important in retrospect when justifying treatments that patients have or have not received during this period.
Absolutely.
Andrew, from a vascular surgical perspective, you're similar in that you've got options for conventional surgery and endovascular approaches.
I think very much I alluded to this in my opening remarks, that we've just had a long process with getting some new nice guidance relating to our EVAR trials, and of course they were done well before COVID reared its head, and we were just looking at rebalancing aortic surgery from an increasingly endovascular approach to more open surgery, and that has happened over the last few years. And I think this very much may push things the other way, because open aortic surgery inevitably is a significant ITU stay and exposure, whereas an endovascular approach to aortic aneurysms, now with new percutaneous closure, we're often sending patients home the next day, and some units are even applying day case surgery to endovascular surgery. Same is true with peripheral intervention, and in the current era, a long bypass procedure might expose you to substantial risk in theatre. Now, I think the difficulty we have at the moment is quantifying that risk, and I think your point is well made about the MDT discussion and actually documenting differences in treatment, because we're actually concerned about COVID, and that's one of the things that we're looking at in the cover study that's been organised by our trainees network is actually recording the difference in treatment and outcomes in this current climate.
Okay, thank you very much. Sri, I'm going to move on to you now, but ask you sort of two slightly separate questions. The first was a question that came up before we had the technical glitch, and that was from Mr. Rajesh, and it was about, do you feel that the Society SCTS guidelines related to the management of lung cancer are being followed, or is it possible to follow them?
So thanks, Tim. We are following the college guidelines as well as the various society guidance within resource limitations, because there are hospitals which are completely swamped with COVID patients that they're not operating at all. But every MDT takes the college guidance, the BTS, BTOC guidance, and prioritizing patients and offering them what would be the best treatment in the situation with least impact on their morbidity and their disease process. Likewise, the other guidance which the college came up, the society came up with, was the preparation of patients, which I alluded to in terms of the screening, the CT. That has been a challenging proposition to implement across the various hospitals, speaking to colleagues. So there are challenges, but we are trying our best to stick to guidance. And more importantly, as Mike said earlier, is documenting that this is the reason why we are doing. Some of our referring hospitals like Northampton have a COVID ethics committee. So in a patient who is high risk to have an operation, when the intensive care team says, look, we're not going to let you operate, it goes to the ethics committee, the risks and benefits are documented, and then a majority committee decision is made. So there are various practices which happen across.
Okay, that's the first question. The second question actually came from Ian Ramnarine, who's in the Caribbean. Lucky chap. Good evening, Ian. Sri, what preoperative COVID testing should we be using prior to thoracic surgery? And is this varying between units?
It is varying between units. The recommended model, which the Society for Cardiothoracic Surgery has circulated to all units, comes from the Barts Hospital. So Barts have come with a robust preoperative screening pathway, both for cardiac surgery, thoracic surgery, and all specialties. And the ACTS recommends that, which includes self-isolation for 7 days before surgery, a throat swab done 48 hours before surgery, and if both are negative, patients brought in and they get a CT scan of the chest to look for asymptomatic patients having pulmonary changes. If all of that's negative, the patient has a bronchoalveolar lavage done on table, because then you're getting a deep sample from the lung, all of which is tested for virology. Now, there's been challenges across various units. With some units, the radiologist saying there is no evidence to it. There is a lot of false positives, but slowly, one unit after the other, units are starting to follow the practice. Barts state that they have not had a conversion in the time they've implemented this screening tool, so the other units are catching it.
Is that what you're doing, Sri?
As of this week, yes.
Okay, all right. Real-time changes to management. So, Edward, if I could ask you a question, training perspective. So this is Lamar, who's joined us from Algeria. Good evening, Lamar. His question really is about whether simulation, surgical simulation, what the approach to that should be, do you think, Edward, during this time, in terms of both maintaining technical skills for the trainees and also potentially, I suppose, in assessment?
I think it's a very interesting question. I think the answer varies by training grade and level of skill to begin with. The answer is there's definitely a role, and we know this not only in the time of a pandemic, but across the board. There are specific cost and resource implications, especially for very high fidelity models, and it does ultimately boil down to what each individual has available locally. I quite liked Lamar's wording of the question. essentially integrating the use of technology for remote evaluation, remote assessment, and remote feedback. I think units that managed to establish this, wherein there's buy-in from experts, mentoring trainees on various simulation models, and also potentially as collaboratives across countries and across regions. I think it's something that has great potential. Its ability to replace training is obviously still very much a topic of discussion, and it has to be considered more as an augmentation rather than anything else. And ultimately, the question of how it will eventually translate to patient safety and to the development of skills to that level of translation is still an open one. So it's a very non-committal answer, but it's definitely something worth considering.
And just to add to that, interestingly, one of the pillars of improving surgical training was about having improved access to simulation training across all the regions of the UK, and that should potentially be extrapolated internationally. And I'm aware, particularly through our cardiothoracic, cardiac surgical wet labs, how valuable that kind of relatively high fidelity simulation training can be. And I know that the Society Cardiothoracic Surgeons put quite a lot of store by it as well. But if you don't mind, I'm going to move on now. Dean raises an interesting point, really about teamwork and about the ability for the team to work in a difficult environment, particularly wearing PPE. So I'm going to ask all the three specialty representatives about how they feel wearing PPE. What's the impact of their ability to be able to operate, and how the team works? Michael.
I was fearful of doing a case in PPE. I have to say it was something that actually, when I came to do it, wasn't quite as bad as I thought it might be. The challenge is being able to hear. That basically, I wasn't able to. The mask didn't fit me, so I had to wear the hood thing, and it's quite noisy, and you can't really hear as well as you normally can. And so Dean makes a good point about sort of the human factors aspects of delivering safe care for patients. And I think, if we're going to look at positives from this, I think, it allows us just to reflect and think about those human factors, things that, perhaps we usually take for granted, but actually by focusing on these issues in the delivery of a safe operation, thinking about how we communicate, making sure that we're clear, making sure that we've got closed loop communication going on so that you're sure that the person's heard what you're saying, those sorts of things, may help us as we move through this and come through the other side of it. It isn't the same as doing it without PPE. There's no doubt about that. It's not as comfortable, and certainly long cases, even with just the hood on rather than having to wear a mask, it is cumbersome and uncomfortable. And for those team members who have to wear a mask, I know that those things are very sore after a prolonged period. Of course, one has to make careful trips before one starts a long operation, make sure that you're not having to pop out of theatre halfway through, make sure you're fed and watered as well. All of those sort of considerations that perhaps normally you wouldn't necessarily have to think on about, you have to sort of bear in mind. So there are definitely adaptations one has to make. It does potentially impact on patient safety, but I think there are certainly in theatre that I've run, it is surmountable, although not necessarily straightforwardly.
And Betsy from Leeds made a very good point that currently they're operating with 2 consultants, especially for long cases, to enable some element of relief. I know that if I was doing those long cases, I'd probably have to nip out to the loo, but anyway, which is probably quite a major event. Anyway, Andy Garnham, vascular surgery, any particular perspectives with PPE, team working?
So, yeah, very much. I'd echo Mike's view on this, in that I've done several vascular cases now in PPE. It's not comfortable, and we've looked to actually having not necessarily two consultants operating at the same time, but people able to operate in sequence and split the case. I think the other thing about it is it reminds you that actually, because often with the current rearrangement in the staffing, it is the fundamentals of actually getting the briefing right, because we certainly are more likely to be operating with team members from nursing and allied health professionals that are not familiar with vascular surgery. So I think it's the human factors element of this is really important. Thank you very much.
Sri, you alluded earlier to quite what sounded high risk bronchoscopic procedures in order to try to evaluate the risk of your patients prior to surgery. What's your perspective on working in PPE and the difficulties that it brings? Any tips?
Well, I echo what Mike and Andy have said. With the thoracic surgery, all of us have been treating all patients as COVID positive. So you're wearing the full kit. The anaesthetists are the ones who suffer the most because our hospitals sourced World War II type respirators. It's like Maverick and Top Gun, but you can't hear the anaesthetist, and they have a tight fitting mask and they do drain them within a couple of hours. So that puts the onus on the surgeon to operate quickly. Andy alluded to the other fact, which is you're working with a new team. Because of theatre resource management, you may pitch in and you're in a completely different theatre, completely different anaesthetist than who you normally are working with. Plus your theatre staff are people who have not done thoracic surgery and they're wearing PPE. So you have to explain before the operation what instruments you may need in a hurry when there is a hole in a blood vessel. The other thing which the previous speakers alluded to about dual operations, we kind of look at it in a slightly different aspect, in that if you have a senior trainee, they could easily be your second surgeon, and it ticks the box of training under duress as well as getting everything through.
That's a very good point. So thank you for that. Sri, you'll see there's a question coming from Cameron about thoracic CT scanning. Maybe you could just type your answer into that while I go to Andy. Andy, we had a question lodged with us before this evening, essentially related to vascular access for dialysis patients, that this is a lifeline for them. And so how are these procedures being categorised and undertaken at the minute during this pandemic?
So what part of the question was framed around insertion of lines, and we've tried to steer away from lines for many years because we know it affects long-term outcome. I think what we have been able to do in this current climate is actually a lot of our renal access surgery is local anaesthetic day case surgery. And we have done that in an area of the hospital that is largely COVID-free, related to the day surgery unit. So I think there are opportunities to do some of this surgery in a relatively protected area. It's part of our practice that we've focused on and actually become more productive with, because it's one of the few elements that we don't need anaesthetic and critical care for.
Okay, thank you very much. Maybe if I could just ask again, Mike, Andy and Sri, if there's been any changes that you've made to the operating room, the operating theatre environment in terms of the resource, number of people in there, any changes to practice, such as the ventilation. I'll start with you, Mike, because Andy's looking a bit puzzled. Okay.
Well, in terms of personnel, we've clearly decided to try to limit exposure. So we have bare minimum of people. We do not have visitors and observers and all of the things that we perhaps would have had before COVID. We're very strict about having everybody in theatre when we start, and everyone stays in until we finish. There's no traffic in and out. And so in terms of sort of good theatre practice, that has been a change. I'd like to echo something that Andy mentioned, which is that we have redoubled our focus on the sort of WHO moments, the sort of board briefing. We're really clear about what we need, so we've not got need to run out to go and get something halfway through and all of those sort of potential exposures to those outside the theatre by doing that. We've got a clear brief before we start, and we also debrief. We're thinking about communication. I was talking to Tim Jones, one of the surgeons in Birmingham today, about some human factors teaching that he's been doing, and he's been talking to his teams about basically doing what we do every day, but just really doing it as best we can. Thinking about, he had a good quote. He said, "We don't rise to the occasion when we're doing an operation. We fall back on the training and doing what we do every day." And I think that's a really sensible way of thinking about it. You're really just trying to do the very best of what you do every day. Thinking about the ventilation question, I think there's been some conflicting advice around what we should do with that. We've taken advice from our own trust. We've put it to the sort of powers that be within the trust. And there's been some adjustment in the flow rates, but we haven't turned it off, which I think was at one time one of the bits of advice, because we felt that we were trying to balance the risk of wound infection to the patient versus the risk of COVID being washed around the unit. And of course, very difficult to do that. I think the current advice is that you should have an air change at least it should remove any aerosol within 10 minutes. And I think that's what we're set for at the moment in our unit.
Okay, Sri, thoracic surgery.
In terms of the general management, it is almost like what Mike said. It is one important thing of ensuring all the staples and devices we have is within the theatre, because normally it is in a central store area with staff going and fetching it if you need it in a hurry, but we have to think an operation through. The other thing, and you touched upon it in the previous question, is the bronchoscopy, which is a high aerosol generating with the jet ventilator. So we've made modifications so that there is no flow out blowing onto the surgeon, although the surgeon's wearing full PPE to minimize risk. The biggest implication, other than the theatre staff in reducing the flow and everything, is our ability to double up and do cases, because normally the second patient would get lined and will have an epidural while we're finishing the first one. We can't do that anymore because we have to get this patient out, recover, extubate, send them to the HTU.
But preoperative planning and the briefing sound absolutely essential.
Absolutely.
Or even greater emphasis on them.
Yeah.
Andy?
So we
surgery?
changed with mix of theatre staff. We've got our elective theatre or urgent theatre is shared with general surgery, head and neck. So scheduling cases is a challenge. And in terms of the staffing of that, of course, it is preparation in terms of what you might need. And yeah, having a runner in the theatre, but also somebody outside the theatre, because a lot of the stuff is not stored centrally. We've moved to our day case theatres, which is slightly geographically remote from the main theatre we were in before. So that's made a major change. In terms of the ventilation, I share Mike's confusion because we have had advice to switch the positive pressure off, and that's changed to turning it back on again. And similar in terms of the air changes, and whether it will change again, I think I remain uncertain.
It sounds like it's essentially a trust-based decision.
I'm not sure there is any good national guidance. I'd be interested to know if anybody's seen anything from the infection control end. Certainly I haven't.
If any of our colleagues online know anything, please pop it into the question and answer box to help with the general audience. I'm aware that we've come now to 8:15. The webinars are intended to run for an hour, but we've deliberately gone on for 15 minutes in view of the technical glitch we had around 20 minutes into the session. I think just my final question is sort of a relatively technical question in relation to cardiothoracic surgery, and that is related to the use of ECMO. And I just wondered, Sri, you are working in Leicester, which is one of our national ECMO centres. Have you any perspective on the experience there with ECMO for COVID patients, and what's happening in terms of thoracic surgical patients potentially going on to ECMO at the moment?
So I'll take the second question first. None of our patients are going into ECMO. The general use of ECMO has gone up. So if you take Leicester, the front door admissions have definitely reduced for the last 2 weeks. Patients getting intubated and going to the intensive care have reduced. However, our ECMO capacity is to the full. And national guidance is they want us to go up to 30 beds of ECMO, which we do not have resource. So the implication is our regular nurses are helping with ECMO service. As a thoracic surgeon, we've been involved in problem sorting with ECMO patients. So patients who have a tracheostomy on ECMO require bleeding and lavage, or patients who need chest drains, then bleed, need surgery. And you have one of your panelists who took 3 patients to theatre over the weekend, which he just did. Edward was involved with 3 patients over the weekend, on all ECMO patients needing bronchoscopies, drains, and exploration for bleeding. So that's been the thoracic surgical involvement in it.
So there's thoracic surgery work in general generated by the ECMO patients, the ECMO population. Do you, slightly unfair maybe, but do you have a feel for the patients that Leicester are accepting for ECMO?
I don't know what the criteria is because it is run by the ECMO team.
Okay. And Mike, from an adult cardiac surgical perspective, we use ECMO for essentially circulatory support or cardiac support. Where does ECMO figure for you at the moment, potentially?
Well, we're not an ECMO centre. We have a very early hub and spoke arrangement with St Thomas's, and in a sort of rather heart-sink moment, our ECMO machine arrived, I think it was the second week of March, and we instantly put it back in its box and sent it straight to St Thomas's, to where we felt that it would probably do a better job than we were able to use it locally. So it's currently sitting in St Thomas's with a patient attached to it, I believe. So whilst I think ECMO will become a more widely available resource in many units, the sort of the development of hub and spoke models and so on to allow patients to be placed on ECMO in early parts of their critical illness and then being managed in specialist centres, to my mind, seems to be the sensible model. And of course, that's probably more in the AV ECMO rather than VV ECMO, where often patients can be managed until the ECMO machine is available. AV is a bit more emergent. I understand that from what I've heard, that the impacts of COVID are not purely respiratory as one might imagine, and that there are patients who are requiring circulatory support because of the myocardial depression, particularly the right ventricle, I understand, takes a real knock with COVID in some patients. And so, well, rather than it being just purely a VV ECMO experience, I understand that AV ECMO is also an important part of the management strategy for these patients, some of these patients. And so, clearly, in a very sort of simplistic cardiac surgical, there's a problem with the pump or the oxygenator. We can probably fix both of those with ECMO. It's a very straightforward solution, but of course, delivery of that to a significant number of patients to make a big difference is a huge headache because of the resource implications. And I understand that ECMO circuits and the ECMO machines and the staff to run them are running at pretty much maximum as things stand, and the circuits particularly are running out. So I think there are major logistical issues to delivering a greater service. As I said, hopefully in the UK at least, we're reaching the peak of our certainly our first peak of this, and hopefully with time, as the peak recedes, our services will become unswamped and therefore able to cope. But I think at the moment the Sri implies they're all working pretty maximally, and there isn't really much room for further patients if they need it.
And certainly it has a major impact on resource utilisation within ITUs in non-national ECMO centres. I think as the time's now approaching 8:20, I think probably we should round up. But a couple of points really. Both Dean and Sunil Badir have put comments in the question and answer box related to ventilation in theatres, that there is PHE advice, and that ventilation in both laminar flow and conventionally ventilated theatres should remain fully on. So thank you for those comments. Another one probably for you, Sri. Kamran again is making a point about CT scanning potentially as a screening tool. And so maybe again, if you get the opportunity, you could type your answer to that. I'd like to thank the audience, colleagues out there who've contributed to the questions and answers. I've certainly found it very interesting and educational. On behalf of all the attendees and the College of Surgeons of Edinburgh, I'd like to thank Mike Lewis, Andrew Garnham, Sri Rathinam and Edward Karuna for both giving up their time and their expertise this evening. I wish you all a good evening, and I hope that you all remain safe and well. Thank you for contributing and participating, and good night.
Thank you.